Prospective comparative study of lenticular thickness and effective lens position in diabetics and non-diabetics undergoing cataract surgery in a tertiary care center. As we know that nowadays patients have heightened expectations for the visual outcome post-cataract surgery. Therefore, accuracy in the IOL power calculation is very important apart from the surgeon's surgical skill. Anterior chamber depth is important because it is an indirect measurement of the effective lens position, that is ELP, which is distance between cornea and the anterior surface of the IOL. Diabetes prevalence is increasing nowadays, and we know that diabetes causes changes in the osmotic property of the lens. Therefore, our main objective is to calculate the lenticular thickness in diabetics and non-diabetics preoperatively, and to calculate and compare the ELP, that is effective lens position, and the visual outcome post-operatively between both the groups. So therefore, we want to compare about the diabetes. We want to know about the diabetic impact on the eyes. The methodology is 100 cataract patients who presented to our OPD. They were of the age group of 40 to 70 years, and they were divided into two groups, 50 diabetics, 50 non-diabetics. The study period was 18 months, and comprehensive examination, visual examination was done, and biometry was done using APPA AMAX scan, which was using SRKT formula in all the cases. Lenticular thickness and ACD was measured, and cataract surgery was done. That was manual cataract surgery, and 1 month post-operatively, the vision was assessed and the anterior chamber depth was assessed. Patients were followed up and the results were compared and analyzed. So our results were, the majority of them were in the age group of 60 to 69 years. Majority were females. Majority of the right eye was operated, and IOL used was between the range of 12 to 28 diopters, in which majority were in the 22 to 24 diopters. The pre-operative ACD in both the groups were not statistically significant, and the post-operative ACD in both the groups were also not statistically significant. What was statistically significant was the lenticular thickness in the diabetics, which was statistically significant, and diabetics tend to have a thicker lens, that was 4.2, and non-diabetics had a thinner lens, that is 4. But the cataract definitely had the change in the ACD values, like intra-group statistical significance was significant, like in non-diabetics pre-operative ACD and the post-operative ACD was statistically significant, and same in the diabetic group also. The main outcome of our study was the spherical error. The spherical error was not much, that it was 0.5 diopters in 50% of both the groups, and it was not statistically significant. So therefore, our study concludes that diabetic patients had the thicker lens, and the other studies also had the similar results. The anterior chamber depth preoperative was in the range of 2.7 in diabetic and non-diabetic group. That was also comparable in the other groups. It was the same in the other studies. So even though we know that the anterior chamber depth has the correlation in the it is the indirect measurement of the effective lens position, but here in our study we couldn't find anything as such. Nearly 50% of both the diabetic and non-diabetic groups had no post-operative surprises and had no post-operative refractive error. It was less than 1 diopter, and equal good results were seen in both the groups using SRKT formulae. Thank you.
You actually seem to have just found a slightly thicker lens in the diabetics as compared to the non-diabetics. And while you have said statistically significant, your p-value is not mentioned. So do you
p-value is 0.38, ma'am.
0.38.
Yes.
So that is not
0.038. Sorry, this 0.038. My slide.
That's mildly significant, if at all. And when you are mentioning pre and post AC depth, you are looking in the same group. You are looking at controls pre and post. You are looking at diabetics pre and post. Of course, it's going to increase post. Your IOL is much lesser thickness than a natural lens. So that is a no-brainer, actually. Was there a difference between the AC depth pre and post amongst the two groups, across the two groups? You are comparing controls and diabetics.
No, so yeah, controls and diabetics, when we compared in the pre-op and post-op, after the cataract surgery was statistically significant.
In the same group, you are compared pre of cataract with pre of control with post of control, and you have compared pre of diabetics with post of diabetics. What about post surgery AC depth of control versus post surgery AC depth?
Also we have compared, ma'am. Like we have compared both the things. Pre-operative ACD in diabetics and pre-op ACD in non-diabetics. That was not statistically significant. Post-op in diabetics and post-op in non-diabetics, that was also not statistically significant.
Exactly. So what benefit do we gain from this knowledge? Did it make any difference? Was the thicker lens causing any problems in surgery? Was it causing any shallowing of AC? Was surgery more complicated due to that?
No, we couldn't find in our scenario. We didn't had much significant on this thing.
Bottom line is that what is the rationale of this study? What did you wanted to prove? Which hypothesis you wanted to prove? What like the house what was the rationale?
The lenticular thickness, what we found was lenticular thickness was more in diabetics, but visual outcome. Yes.
Why?
What is the cohort?
Why?
It is bound to occur. What was the rationale?
Why was the lens thicker in diabetics as compared to controls?
Because of the osmotic changes, ma'am. We wanted to know that if lenticular thickness is more, then then the ACD will reduce.
It is the sugar is getting metabolized through sorbitol aldose reductase pathway.
Yes.
That is, we are all known to it. What was the rationale of the study? Once it is 200 milligram % more than that, hexokinase become redundant. Aldose reductase start taking place.
Yes.
Mechanism of the utilization of the glucose start taking place.
No,
So
because we
aldose
wanted
reductase pathway.
to-
Rationale बताइए. क्या
No,
rationale?
the thing is, we wanted to prove that if that lenticular thickness, the idea behind the study was if the lenticular thickness is more, then the ACD will reduce. And that ACD reduction might have any change in the IOL. But we couldn't find any such correlation in our study.
Okay, it's
That
okay.
was the main idea behind our
Okay,
study.
thank you.